Question 1. A 68-year-old male is admitted for severe lower back pain and weakness in his legs. Imaging reveals a herniated lumbar disc with severe myelopathy. The patient undergoes a lumbar laminectomy for decompression with interbody fusion at L4-L5 using an interbody fusion device and bone graft obtained from the iliac crest, autogenous. Which CPT codes should be reported? A. 22633, 20938. B. 22633. C. 22630, 20938. D. 22612, 20938. Answer: A. 22633, 20938. This question tests the proper coding of a lumbar interbody fusion with concurrent bone graft harvesting. The keyword interbody fusion and L4-L5 points to code 22633, which specifically describes lumbar interbody arthrodesis, posterior approach, single interspace, with decompression of facets and/or foramen. Since an autogenous bone graft from the iliac crest was harvested and used, code 20938, autogenous bone graft, local, e.g., cortical or cancellous, should also be reported separately, as it is not bundled into 22633. Always remember to check for separate reporting of bone graft harvest if it's autogenous and not inherent to the primary procedure code. Question 2. A patient with a history of hypertension and diabetes presents to the emergency department with sudden onset of severe abdominal pain. After evaluation, the physician determines the patient has acute appendicitis. An appendectomy is performed. Which of the following conditions would be considered a principal diagnosis for inpatient admission? A. Hypertension. B. Diabetes. C. Abdominal pain. D. Acute appendicitis. Answer: D. Acute appendicitis. This question focuses on identifying the principal diagnosis for an inpatient admission. The key concept is that the principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. While the patient has other medical conditions like hypertension and diabetes, the sudden onset of severe abdominal pain leading to a diagnosis of acute appendicitis is what caused the patient to be admitted and undergo surgery. Therefore, acute appendicitis is the primary reason for this hospital stay. Always ask yourself, why was the patient admitted, to determine the principal diagnosis. Question 3. A 45-year-old female presents to the physician's office for a follow-up after a recent hospitalization for acute myocardial infarction, MI. She is stable, and the physician performs a problem-focused history, an expanded problem-focused examination, and low-complexity medical decision-making. Which E/M code should be reported? A. 99203. B. 99213. C. 99214. D. 99204. Answer: B. 99213. This question tests the correct E/M coding for an established patient office visit using the 2021 E/M guidelines based on medical decision-making, MDM, or total time. The patient is an established patient, follow-up visit, eliminating new patient codes 99203 and 99204. The physician performed low-complexity medical decision-making, which directly maps to CPT code 99213. Even though the history and exam elements are described, for office/outpatient E/M services in 2021 and beyond, MDM or total time are the key components for code selection. Always look for the stated level of medical decision-making or total time documented when coding established office visits. Question 4. A patient is admitted with severe sepsis due to urosepsis, presenting with acute organ dysfunction documented as acute kidney failure. The documentation specifies that the sepsis is severe and directly resulted in the kidney failure. How should these conditions be sequenced and reported according to ICD-10-CM guidelines? A. R 65.20 and 39.0. B. N 39.0 R 65.20. C. A 41.9 and 39.0 R 65.20. D. A 41.9 R 65.20 and 17.9. Answer: D. A 41.9 R 65.20 and 17.9. This question tests the sequencing and coding of sepsis with associated organ dysfunction, a common and often challenging scenario. The primary concept here is that a code from subcategory A41, other sepsis, is sequenced first when sepsis is severe, followed by the code for severe sepsis, R 65.20, and then the code for the acute organ dysfunction. The documentation states severe sepsis due to urosepsis, which defaults to A 41.9, sepsis, unspecified organism, and acute kidney failure, which is N 17.9. Therefore, A 41.9 is the principal diagnosis, followed by R 65.20 to indicate severe sepsis, and N 17.9 for the acute kidney failure. Remember to always code the underlying sepsis, then the severe sepsis, then the specific organ dysfunction. Question 5. A 55-year-old female undergoes a total abdominal hysterectomy with bilateral salpingo-oophorectomy for uterine leiomyomas. During the postoperative period, she develops a deep incisional surgical site infection in the abdomen, which requires incision and drainage in the operating room. What is the correct way to code the incision and drainage procedure? A. CPT code for incision and drainage with modifier -78. B. CPT code for incision and drainage with modifier -79. C. CPT code for incision and drainage without a modifier. D. CPT code for incision and drainage with modifier -58. Answer: A. CPT code for incision and drainage with modifier -78. This question tests the appropriate use of CPT modifiers for procedures performed during a global surgical period. The concept being tested is unrelated procedures versus unplanned return to the operating room for a related procedure. Since the deep incisional surgical site infection is a complication of the original surgery and required a return to the operating room for treatment, modifier -78, unplanned return to the operating room for a related procedure, is the correct choice. Modifier -78 indicates that the procedure was performed in the operating room, was related to the original surgery, and occurred during the global period, typically resulting in payment for the intraoperative portion of the service only. Remember that modifier -78 is specifically for a return to the operating room for a related complication or other unanticipated circumstance. Question 6. A patient is seen in the outpatient clinic for routine post-surgical follow-up after a cataract removal performed 2 weeks ago by the same ophthalmologist. The visit documentation includes only stable, no complaints. What is the appropriate charge for this visit? A. A low-level E/M code, e.g., 99212. B. A mid-level E/M code, e.g., 99213. C. A post-operative visit code, e.g., 99024. D. No charge is typically made. Answer: D. No charge is typically made. This question tests understanding of the global surgical package concept for CPT coding. The key concept is that routine, uncomplicated post-operative visits are included in the global surgical package payment for the original surgery. A routine post-surgical follow-up within the typical 90-day global period for cataract removal, with documentation indicating stable, no complaints, signifies an expected part of the surgical care. Therefore, no separate charge is typically made for this visit, as its services are already encompassed by the fee paid for the cataract removal. Always remember that services integral to the recovery from a surgery, occurring within the global period, are generally not separately billable. Question 7. A 72-year-old male with a history of chronic obstructive pulmonary disease, COPD, is admitted with acute exacerbation of COPD and pneumonia. Documentation indicates the pneumonia is due to Haemophilus influenza. Which of the following is the correct ICD-10-CM coding for this admission? A. J44.1, J14. B. J14, J44.1. C. J44.0, J14. D. J44.1, J18.9. Answer: A. J44.1, J14. This question assesses the correct sequencing of chronic obstructive pulmonary disease, COPD, with acute exacerbation and pneumonia due to a specific organism. When COPD with acute exacerbation is documented with pneumonia, the code for COPD with acute exacerbation, J44.1, is sequenced first. This is followed by the code for the specific type of pneumonia. In this case, pneumonia due to Haemophilus influenza translates to J14. Therefore, J44.1 is the principal diagnosis, followed by J14. Always prioritize the code for COPD with acute exacerbation when pneumonia is also present, and then specify the pneumonia. Question 8. A patient presents for a scheduled colonoscopy screening. During the procedure, the physician identifies a 1.5 cm sessile polyp in the sigmoid colon and removes it using a hot biopsy forceps. What CPT code should be reported? A. 45,378. B. 45,384. C. For 5378, 45,384 to 59. D. 45,385. Answer: D. For 5385. This question tests the coding of a diagnostic colonoscopy that converts to a therapeutic procedure. The key concept is that when a screening colonoscopy for 5378 identifies a lesion and a biopsy/polypectomy is performed during the same encounter, only the therapeutic code is reported. The hot biopsy forceps technique points to code 45385, colonoscopy, flexible, proximal to splenic flexure, with removal of tumors, polyps, or other lesions by hot biopsy or electrocautery snare technique. Code 45385 encompasses both the diagnostic examination and the therapeutic removal. Do not report 45378 separately. The higher-valued therapeutic procedure includes the diagnostic scope. Question 9. A patient is undergoing inpatient chemotherapy for a malignant neoplasm of the lung. During the infusion, the patient experiences severe nausea and vomiting due to the chemotherapy agent. The physician orders antiemetics and supportive care. How should the nausea and vomiting be coded for this encounter? A. R11.2, nausea with vomiting, unspecified, Z51.11, encounter for antineoplastic chemotherapy. B. Z51.11, encounter for antineoplastic chemotherapy, only. C. T45.1x5a, adverse effect of antineoplastic and immunosuppressive drugs, initial encounter, R11.2, nausea with vomiting, unspecified. D. K92.0, hematemesis. Answer: A. R11.2, nausea with vomiting, unspecified, Z51.11, encounter for antineoplastic chemotherapy. This question tests the coding of adverse effects of medication in an inpatient setting, specifically when the medication is properly administered. The keyword "due to the chemotherapy agent" indicates a direct side effect of the intended therapeutic use of the drug, not an overdose or poisoning. Per coding guidelines, when a patient is admitted for an adverse effect of a drug that was properly administered, the adverse effect, e.g., R11.2 for nausea and vomiting, is typically sequenced first as the principal diagnosis, followed by a code for the therapeutic encounter, Z51.11. However, in this specific inpatient scenario, the patient is still receiving their chemotherapy, so the chemotherapy encounter, Z51.11, is the reason for the admission, and the nausea and vomiting, R11.2, are a co-occurring condition. An adverse effect code from T45.1X5A would be used if the admission itself was specifically for the treatment of the adverse effect, but here, the patient is continuing with chemotherapy. Always remember to consider if the reason for admission is the adverse effect itself, or if the adverse effect is a complication during ongoing treatment. Question 10. A 48-year-old female presents for her annual mammogram. Due to dense breast tissue, the radiologist recommends and performs a screening breast ultrasound of both breasts on the same day. How should these services be reported? A. 77067, 76,641-59. B. 77067, 76642. C. 77067, 76,642-59. D. 77067, 76,642-76. Answer, B. 77067, 76642. This question addresses the coding for screening mammography followed by a screening breast ultrasound on the same day. The concept is that a screening mammogram, 77067, and a screening breast ultrasound, 76642, are distinct, separately billable procedures when performed for screening purposes. The key is that the ultrasound was recommended and performs a screening breast ultrasound, indicating it was still for screening, not diagnostic follow-up of a specific finding. Therefore, 77067 for the screening mammogram and 76642 for the screening breast ultrasound, complete, bilateral, are both reported. No modifier is needed because NCCI edits do not bundle these two codes when both are performed for screening purposes. Always differentiate between screening and diagnostic imaging when selecting codes and applying modifiers. Question 11. A patient is admitted to an inpatient hospital for elective laparoscopic cholecystectomy for chronic cholecystitis. During the procedure, the surgeon encounters severe adhesions, making the laparoscopic approach unsafe. The surgeon converts the procedure to an open cholecystectomy. Which ICD-10-PCS code should be reported for this scenario? A. 0FB40ZZ. B. 0FB40ZZ, 0FBC0ZZ. C. 0FBC0ZZ. D. 0FBC0ZZ, 0FB40ZZ. Answer, C. 0FBC0ZZ. This question tests the coding of a laparoscopic procedure converted to an open procedure in ICD-10-PCS. The core concept is that when a laparoscopic, percutaneous endoscopic, approach is started but then converted to an open approach during the same operative session, only the open approach is coded. The keyword converts the procedure to an open cholecystectomy is crucial. The code 0FBC0ZZ represents excision of gallbladder, open approach. You do not code the attempted laparoscopic procedure because the completion of the procedure determines the final approach. Always code the method by which the procedure was completed, not the initial attempt. Question 12. A patient undergoes an MRI of the brain without contrast due to a history of claustrophobia. The radiologist notes a suspicious lesion. The patient is immediately brought back for an MRI of the brain with contrast. How should these services be reported? A. 70551, 70,553-59. B. 70551, 70552. C. 70,553. D. 70551, 70,552-59. Answer, C, 70553. This question tests the correct coding for MRI studies performed without and then with contrast on the same day. The core concept is that if an MRI is performed without contrast, followed by with contrast, the code that represents the with and without contrast study should be reported. The key clue is that the patient had an initial MRI without contrast, and then immediately brought back for an MRI of the brain with contrast to further evaluate the suspicious lesion. CPT code 70553 represents magnetic resonance, MR, imaging, brain, with and without contrast material. You should not bill 70551 and 70552 separately with a modifier, as 70553 is the comprehensive code for this scenario. Remember that CPT often has combination codes that fully describe a service when performed in a sequence. Question 13. A patient is admitted for a total knee arthroplasty due to severe osteoarthritis of the right knee. Postoperatively, the patient develops aspiration pneumonia from vomiting caused by opioid pain medication. The pneumonia significantly prolongs the hospital stay. What is the present on admission, POA, indicator for the aspiration pneumonia? A, Y, yes. B, N, no. C, U, unknown. D, W, clinically undetermined. Answer, B, N, no. This question tests the application of present on admission, POA, indicators for complications. The core concept is that a condition that develops after admission, even if it's a complication of a treatment or pre-existing condition, is generally marked N, not present on admission. The phrase postoperatively, the patient develops aspiration pneumonia clearly indicates the pneumonia arose during the hospital stay, after the admission for the knee arthroplasty. Even though the vomiting was due to medication given during the hospital stay, the pneumonia itself was not present when the patient was initially admitted. Always mark N for conditions that originate or manifest after the patient's inpatient admission. Question 14. A 62-year-old male with a history of heart failure, stage C, presents to the emergency department with acute decompensated heart failure, ADHF. The physician admits the patient to observation status for management of ADHF. What is the correct principal diagnosis code for this observation stay? A, I50.20, acute heart failure, unspecified. B, I50.9, heart failure, unspecified. C, I50.33, acute on chronic diastolic heart failure. D, I50.32, chronic diastolic heart failure. Answer, A, I50.20, acute heart failure, unspecified. This question assesses the principal diagnosis for an observation stay, especially concerning acute on chronic conditions. The core concept for outpatient principal diagnosis, which includes observation stays, is to report the diagnosis, condition, problem, or other reason for the encounter/visit shown in the medical record to be chiefly responsible for the services provided. The patient presented with acute decompensated heart failure, ADHF, and was admitted for management of ADHF. While the patient has a history of heart failure, stage C, the acute exacerbation is the primary reason for the observation. Therefore, I50.20, which is for acute heart failure, is the most appropriate principal diagnosis because it specifically identifies the acute reason for the encounter, and the documentation does not specify diastolic or systolic type. Always code the acute condition that brought the patient to the hospital for outpatient encounters. Question 15. A patient is scheduled for a bilateral screening mammogram. After the mammogram, the patient complains of a lump in her left breast, which was not seen on the mammogram. The radiologist then performs a diagnostic ultrasound of the left breast to evaluate the lump. How should the ultrasound be coded? A, 76,641. B, 76,642. C. 76,641 to 59. D. 76,641 to 76. Answer: C. 76,641 to 59. This question differentiates between screening and diagnostic imaging and the use of modifiers. The concept is that when a screening service transitions to a diagnostic service on the same day due to a new finding or complaint, the diagnostic service should be reported separately with a modifier. The complaints of a lump in her left breast after the screening mammogram indicates a new symptom requiring a diagnostic study. Code 76641 represents a unilateral diagnostic ultrasound of the breast. Modifier -59, distinct procedural service, is appended to 76,641 to indicate that this diagnostic ultrasound was separate and distinct from any screening services performed. Remember that a screening study turns diagnostic when new signs, symptoms, or findings necessitate further evaluation. Question 16. A patient is admitted to an acute care hospital for management of uncontrolled type 2 diabetes with hyperglycemia. The patient also has documented morbid obesity. During the stay, the patient develops a stage 3 pressure ulcer on the sacrum. How would the morbid obesity affect the MS-DRG assignment? A. It is a principal diagnosis. B. It is a major complication/comorbidity, MCC. C. It is a complication/comorbidity, CC. D. It has no impact on MS-DRG. Answer: B. It is a major complication/comorbidity, MCC. This question tests the understanding of how comorbidities impact MS-DRG assignment. The concept is that certain conditions, known as major complications/comorbidities, MCCs, significantly increase resource consumption and patient severity, leading to a higher-weighted MS-DRG. While the principal diagnosis is uncontrolled type 2 diabetes, morbid obesity, E66.9, is classified as an MCC in the MS-DRG system. The presence of an MCC can shift the MS-DRG to a higher severity level, impacting hospital reimbursement. Always check the official MCC/CC lists as part of the MS-DRG grouper logic to see how secondary diagnoses affect reimbursement. Question 17. A patient is admitted for elective outpatient surgery to repair an inguinal hernia. Due to unexpected intraoperative bleeding, the patient is kept overnight for observation and discharged the next morning. How should the patient's status be coded for this stay? A. Inpatient admission. B. Observation stay. C. Outpatient with extended recovery. D. Inpatient due to surgical complication. Answer: B. Observation stay. This question tests the criteria for inpatient versus observation status. The core concept is that a patient's status, inpatient versus observation, is determined by the physician's order and the expectation of length of stay and medical necessity, not solely by an unexpected event or complication. Despite the unexpected intraoperative bleeding requiring an overnight stay, the initial intent was elective outpatient surgery, and the patient was kept overnight for observation and discharged the next morning. This scenario typically falls within the scope of an observation stay, generally less than 2 midnights, as there was no formal inpatient admission order, and the patient was discharged quickly after stabilization. Always remember that patient status is a physician order-driven decision based on medical necessity criteria. Question 18. A patient is diagnosed with stage 4 adenocarcinoma of the lung with metastasis to the bone. The patient is receiving palliative radiation therapy for painful bone metastases. What is the correct sequencing of ICD-10-CM codes for this outpatient encounter? A. C79.51, C34.90, Z51.0. B. C34.90, C79.51, Z51.0. C. Z51.0, C79.51, C34.90. D. C34.90, Z51.0, C79.51. Answer: C. Z51.0, C79.51, C34.90. This question tests the sequencing of codes for cancer patients receiving palliative treatment in an outpatient setting. The key concept is that for outpatient encounters, when the focus of the encounter is treatment for a specific condition, that condition is typically sequenced as the principal diagnosis. When a cancer patient receives palliative radiation therapy for painful bone metastases, the Z code for the encounter for antineoplastic radiation therapy, Z51.0, is the principal diagnosis. It is then followed by the code for the metastatic site that is being treated, C79.51 for secondary malignant neoplasm of bone, and then the primary malignancy, C34.90 for malignant neoplasm of unspecified part of bronchus or lung. Always remember to sequence the reason for the outpatient encounter first, which, for palliative care, is the Z code, then the site being treated, then the primary cancer. Question 19. A 60-year-old male presents for a routine physical examination. During the exam, the physician discovers the patient has elevated blood pressure and initiates medication for newly diagnosed essential hypertension. The patient has no other complaints or significant findings. Which E/M service code should be reported? A. 99,396. B. 99,203. C. 99396, I-10. D. 99396, 99,213-25. Answer: D. 99396, 99,213-25. This question tests the coding of a preventive medicine service with a separately identifiable problem-oriented E/M service. The core concept is that when a significant, separately identifiable problem is addressed during a preventive visit, both the preventive code and the problem-oriented E/M code can be reported. The routine physical examination is coded with 99,396, periodic comprehensive preventive medicine re-evaluation and management of an individual, 50 to 64 years. However, the newly diagnosed essential hypertension and the initiation of medication constitute a separate, problem-oriented service. This would be coded with 99,213, established patient office visit, level 3, with modifier -25, significant, separately identifiable evaluation and management service by the same physician or other qualified healthcare professional on the same day of the procedure or other service. Always remember to apply modifier -25 when a problem is addressed above and beyond the components of the preventive service. Question 20. A patient presents with acute abdominal pain. A CT scan of the abdomen and pelvis with contrast is ordered. The patient has a known severe allergy to iodine contrast. The radiologist decides to perform the CT scan without contrast due to the allergy. Which modifier should be appended to the CT scan code, e.g., 74177? A. -52. B. -53. C. -73. D. -74. Answer: A. -52. This question tests the use of modifier -52 for reduced services. The concept is that when a service is partially reduced or eliminated at the physician's discretion, modifier -52, reduced services, should be appended. The key clue is that the CT scan was ordered, with contrast, but was performed without contrast due to the allergy. Since the full service, with contrast, was not performed as initially intended, but a modified version, without contrast, was, modifier -52 is appropriate. Modifiers -53, -73, and -74 relate to discontinued procedures or procedures performed in facilities, not the reduction of a service's complexity by physician choice. Always use modifier -52 when a complete service is not rendered due to circumstances, but a modified service is performed. Question 21. A patient is admitted with pneumonia and receives 4 antibiotics. During the hospital stay, the patient develops severe acute respiratory distress syndrome, ARDS, as a direct result of the pneumonia. The physician documents acute respiratory distress syndrome due to pneumonia. What is the correct sequencing of ICD-10-CM codes? A. J80, J18.9. B. J18.9, J80. C. J80, J18.9, R06.00. D. J18.9, R06.00. Answer, B. J18.9, J80. This question tests the sequencing of a pneumonia with a directly resulting complication, specifically ARDS. The core concept is that when a condition directly results in another condition, and both are present on admission or develop during the stay as a cause and effect, the underlying condition, etiology, is sequenced first, followed by the manifestation. In this case, the pneumonia is the underlying cause, and severe acute respiratory distress syndrome, ARDS, is the manifestation. Therefore, J18.9, pneumonia, unspecified organism, is sequenced as the principal diagnosis, followed by J80, acute respiratory distress syndrome. Always look for due to or similar phrases to identify the cause and effect relationship for proper sequencing. Question 22. A patient undergoes a complete laparoscopic colectomy with removal of the entire colon and creation of an ileostomy. Which ICD-10-PCS route operation should be coded for the removal of the colon? A. Excision. B. Resection. C. Division. D. Extirpation. Answer, B. Resection. This question tests the understanding of ICD-10-PCS route operations, specifically for removing body parts. The concept is to select the route operation that most accurately describes the objective of the procedure. For the removal of an entire organ or an entire body part, resection is the appropriate route operation. The keyword removal of the entire colon clearly indicates that the whole organ was removed. Excision refers to cutting out or off a portion of a body part, while division is cutting into a body part without taking out a portion, and extirpation is removing solid matter from a body part. Always remember that resection means total removal of an organ or body part. Question 23. A patient presents to the physician's office with a persistent cough. The physician performs a problem-focused history and examination and decides to order a chest X-ray. The physician documents acute bronchitis, suspected. What is the correct diagnosis codes for this outpatient encounter? A. J20.9. B. R05. C. J20.9, R05. D. Z03.89. Answer, B. R05. This question tests the coding of uncertain diagnoses in an outpatient setting. The core concept is that for outpatient encounters, a suspected or probable diagnosis is not coded as if it were confirmed. Instead, the signs, symptoms, or abnormal findings are coded. The keyword suspected for acute bronchitis indicates uncertainty. Therefore, the persistent cough, R05, is the correct code, as it represents the chief complaint or symptom that occasioned the visit. J20.9, acute bronchitis, unspecified, would only be used if the diagnosis was definitively established. Always code symptoms or signs in the outpatient setting when a definitive diagnosis is not yet confirmed. Question 24. A patient is admitted for a total abdominal hysterectomy due to symptomatic uterine fibroids. During the immediate postoperative period, the patient develops acute kidney injury due to severe dehydration. The acute kidney injury was present on admission and worsened during the hospitalization. How should the present on admission, POA, indicator for the acute kidney injury be reported? A. Y. Yes. B. N. No. C. U. Unknown. D. W. Clinically undetermined. Answer: A. Y. Yes. This question tests a nuanced aspect of POA indicators, specifically when a condition is present on admission but worsens or becomes complicated during the stay. The crucial keywords are acute kidney injury was present on admission and worsened during the hospitalization. Even though the dehydration was identified or worsened postoperatively, the underlying acute kidney injury was already present when the patient was admitted. Therefore, the POA indicator should be Y, yes, as the condition existed at the time of inpatient admission. Remember that a condition is considered present on admission even if it's only later diagnosed or becomes more severe during the stay, as long as it was clinically evident at admission. Question 25. A patient presents to the emergency department, ED, with chest pain. The ED physician performs an expanded problem-focused history, an expanded problem-focused exam, and medical decision-making of moderate complexity. An EKG is performed and interpreted by the ED physician. How should the ED/M service and EKG be coded? A. 99,283. B. 99,284. C. 99284. 93010. D. 99284, 93,000. Answer: D. 99284, 93,000. This question tests the coding of an emergency department, ED, E/M service along with a separately billable diagnostic procedure. The expanded problem-focused history, an expanded problem-focused exam, and medical decision-making of moderate complexity align with CPT code 99284 for an emergency department visit. For the EKG, since the ED physician performed and interpreted it, the global code 93,000, electrocardiogram, routine ECG with at least 12 leads, with interpretation and report, is appropriate because it includes both the tracing and interpretation components. Code 93010 describes the supervision and interpretation only, typically for hospital-based cardiologists. Always ensure that both the E/M service and any distinct diagnostic procedures performed by the same physician are captured when supported by documentation.